A very warm good evening to one and all present here today for the awareness webinar on the awareness program week from 23rd of May to 28th of May. The whole week we'll be celebrating PE, and also we'll try to understand various complications and also innovations done by IRIA Samrakshan and Preventive Radiology team. I would like to invite Dr. Matthew, who's been Secretary of IRIA Kerala and also been backbone of Samrakshan and Preventive Radiology of IRIA. Over to you, Doctor.
Thank you, Soumya. So once again, welcome to today's session on behalf of IRIA Preventive Radiology Committee and the IRIA Samrakshan Committee, and the session being hosted by IRIA Kerala in association with JournoMed and MedPiper. This is a third in the series of the as part of the celebration, as part of the World Preeclampsia Day. Yesterday we had an introduction on Samrakshan, and then Dr. Gulab Chajar had given a talk on the pathophysiology of preeclampsia. So today, as part of the Samrakshan initiative, we want to focus on a subject that is very, very important. That is importance of dating, early dating scans, and that is very, very important. And we have several publications to tell you the important significance of that, because this is the discordant LMPs can be a major problem in our perinatal statistics. This is something that we need to address. A major paper that has been published by Dr. Lelis Sharma from our team on 14,000 pregnancies on discordant LMP by ultrasound, discordant LMP and ultrasound dating. We discovered that this wrong LMPs and wrong estimations can lead to significant, has got an impact on the perinatal mortality in India, because nearly 60% doesn't know their LMP. So we have taken this particular aspect as a single theme for this whole session here. But before going into that academic session, we have the president of Gujarat State Chapter of Radiology and Imaging Association. Gujarat State Chapter is one of the most vibrant and dynamic state chapters of IRIA. And I have the pleasure and privilege and honor to invite and welcome the president of the Gujarat Chapter of IRIA, Professor Dr. Deepak Mehta, who is also the professor and HOD of the Pramukh Swami Medical College in Vadodara. And I welcome you, sir, to this session. And may I invite you to say a few words on behalf on Samrakshan and the preventive radiology activities we would like to take forward in your state.
Welcome to everybody. Thank you very much, Dr. Rijo, for the kind introduction. I think that you are adopted Gujarati. In the Gujarati, you are always considered to be a Gujarati. So I think that it is a time that highly that you from some of our members to adopt as a Keralian and Tamilian in that way, because Kerala is also one of the most academic chapter. I have been in a couple of groups of the Kerala and I get regular information about academics. Tamil Nadu, Karnataka, Maharashtra, Delhi, some of the chapters are very healthy competition, and we want to be in the front bunch of that thing. But anyway, everybody is a friendly thing, and whatever we are going to do is ultimately for the benefit of the radiologist and benefit of our beloved association, Indian Radiology and Imaging Association, along with its academic and the journal wings. So Samrakshan is a program which was started when the Dr. Hemant Patel, one of our own Gujarati dynamic leader, was president of IRIA 3 years back. And he has started this Samrakshan program, and Dr. Riju was, since that conception, with this program, and under his dynamic leadership for this program is gradually progressing. We have launched in Gujarat at 3 places, no doubt Ahmedabad, Vadodara, and in my medical college. We have put that banner of the Samrakshan on the day of 15th May for the Gujarat launch. But the idea of Samrakshan is to give back to the society that maternal mortality and maternal morbidity, as well as the infant mortality rate, is quite high. It is not acceptable at this level when India is wanting to become a 5 trillion economy in the 5 years' time, as per the vision of our beloved Prime Minister, and as for some of the economists who want a growth burst in India. So we have to bring back to the our morbidity and mortality rate as well as the infant mortality rate to the developed countries, or we have to give them what we can say healthy competition in that way to bring down the mortality to an acceptable level of less than 1% for the infant and less than probably 1.5 to 2% for the mothers, which is at present it is quite high. But Sanrakshan is acting on both mother and child. It is considered to be a two questions on which the gynecologist, neonatologist, as well as the fetal medicine specialists work on that. And I think that with the Sanrakshan progressing higher and higher over this, everybody, not only the gynecologist, it is the responsibility of gynecologist, but even we can say fetal medicine or neurologist, it is indirectly a responsibility of us as a radiologist also to diagnose the IUGR earlier, to counsel them, to make them sure about having the safe delivery as well as a child having the safe neonatal period as well as get the normal development during their preschool age group, infantile as well as preschool age group. So looking to that motives, and India is a big country, 1.3 billion people is a big, vast country. So we have to reduce this mortality and morbidity, and that will bring our society in a little bit more front on the health front. IRI is also doing other work related to the health, not only for the patients, but also for the doctors. Like we have started with the Aragya Clinic, we're starting with the Olympics or something to keep ourselves fit. But at the end of the day, we have to give back to the society. And these two areas, maternal mortality as well as infant mortality, these are has to bring down, and we have also an important role to play by diagnosing it early, counseling them early, making the optimum use of the fetal medicine, as well as keeping the obstetrician and gynecology as well as neonatologist ready for whatever the outcome that come when there is a premature delivery or delivery with the IUGR child. With this introduction, I would like to share that there are a lot of people. There is going to be a program device over there. Dr. Lalit Sharma is there. Dr. Akanksha is there. Ramesh Shino is there. Dr. Gulab is there. And I'm sure that we will have a fruitful discussion for next 1 year today, as well as during the whole pre-eclampsia week. So thank you very much to the Kerala chapter and the Sanrakshan team for inviting me. It is going to be a fruitful section, and I'm going to looking forward to learn from the thing, learn few things from this to carry forward in my practice.
Thank you very much, Professor Dr. Deepak Mehta. That was the president of the Gujarat State Chapter of Radiology and Imaging Association, and the message from the state president was to give back to the society, contribute back to the society for the well-being of the society. And that is what Samrakshan and Preventive Radiology is doing. Thank you, Professor Dr. Deepak Mehta, once again. We will now move on to the academic session. I have to introduce a young dynamic speaker and dynamic health activist, I must say, from Harda district in Madhya Pradesh. She has been doing phenomenal work for Samrakshan for the last 3 years. She attended the first CME of Samrakshan in Indore. She got interested in Samrakshan and has been passionately working for Samrakshan. And some of her ideas have been put into use in her own district of Harda. And she has taken the lead to go to the neighboring districts in Madhya Pradesh, in Sioni, in other districts of Madhya Pradesh also, to take the Samrakshan campaign forward. Conducted several reach-out programs to obstetricians and gynecologists, and also to our fellow radiologists in her own district, and even supported their staff and in the training. That is what Dr. Lalit sir, Dr. Akanksha, and Dr. Anjali Gupta, these warriors of Samrakshan, these leaders of Samrakshan, they are so passionately working for it that you ask any help, they are going to provide it. And in terms of, yesterday, Dr. Anjali has offered her support to train the staff of other radiologists in Agra. So that's the kind of commitment and passion with which the Samrakshan leaders of all over India are working. And I am extremely happy to introduce Dr. Akanksha Baghel. She is from Harda, and she will be talking to us on a very important subject that Samrakshan wants to highlight. that is the importance of early dating scan, because this is extremely important for India. Rather than looking at the genetic markers, structural anomalies, we have got very, very vital and basic things to be covered in our practice all over India, which can make such small steps can make a big difference in the perinatal statistics in India. With that introduction, may I invite this young dynamic leader of Samrakshan from Hardha, Dr. Aganksha Baghe. Over to you.
Thank you so much. Thank you, sir. It's always been an honor to be part of the Samrakshan journey.
You can share your screen, Aganksha.
Yes. Okay. Is it visible, sir?
Yes, very much. Please go ahead.
Yes. So, importance of dating scan. Okay. What is dating scan? Every situation in life is a time-bound phenomenon. So, hence the dating is, pregnancy is, different option gynae societies and different association label differently what should be the time period for the dating scan. But roughly we can say the 11 to 13 weeks and 6 days of gestation age means first trimester normally scan should be the preferred as the dating scan. ISIOC society says that it should be when CRL attains 30 mm to 84 mm of the gestation of the size. It should be labeled as dating scan, while American Obstetric Society says that 7 to 9 weeks of gestation of CRL corresponding to 7 to 9 weeks of gestation should be considered as dating scan. But when practically what we see that patient don't come at a point in first trimester scan, they come randomly to us, but whatever the situation is, reassurance or confirmation should be done at the first trimester normally scan. What are the importance of dating scan? Firstly, to confirm the pregnancy. Mostly what we see in our situation that people think that periods should always be regular, and after pregnancy, if they are somehow due to hormonal imbalance, if periods don't come regularly, parents or family person think that she must be pregnant now, and they come directly to the doctors and ultrasound clinic to confirm whether it is what is the situation of pregnancy. So confirmation of pregnancy, though, then we need to look for and sometimes defective UPT kit may show positive, but only the ultrasound scans are the things what can confirm if pregnancy is there or not, and whether we need to correlate with beta HCG. So of course, confirmation of pregnancy is the first step. And to rule out the abnormality like molar pregnancies, it is very easy during first trimester scan to look the surrounding of the fetus and embryo, and it is very easy to diagnose the complete mole. But in the situation of partial mole, if something abnormal is happening surrounding placenta or fetus, only dating scan can confirmly suggest that it should properly things should properly look. And to confirm the location and exclude any ectopic pregnancy, sometimes we need to if patient come with the pain in lower abdomen and all, we need to exclude the possibility of ectopic pregnancy or scar pregnancy, whether it is developing inside the uterus or outside the uterus. It makes important. And to confirm the viability, there are criteria. If we label it, definitely we can say that if it is a failed pregnancy or it is a viable pregnancy, and there occurs in between there is a suspicion for failure pregnancy, but not diagnosis. And this category need to re-evaluate after 7 to 10 days of the scan. Previously, during my practice, what I used to see, and even I was doing that CRL of 4 to 5 mm. I used without cardiac activity. Mostly I used to give it as a failed pregnancy. But later on, I understood that CRL, if CRL is equal to or until and unless it attains the 7 mm of size without cardiac activity, we can't label it as the failure pregnancy. So what are the definite criteria for pregnancy failure? If CRL is more than 7 mm of size without cardiac activity, it is a failed pregnancy. And if mean sac diameter is equal to or more than 25 mm of size without a fetal pole, it is labeled as failed pregnancy. If when after scan, when firstly we scan empty gestation sac, and we go to the review scan after 2 weeks, and we find no fetal pole or cardiac activity, it is definitely a failed pregnancy. Similarly, a gestational sac with yolk sac and review scan after 11 days or more, and we don't find any fetal pole or cardiac activity, we can label it as a failed pregnancy. But we should always offer a review scan in between situations, like if CRL is less than 7 mm of size and do not showing any cardiac activity, if mean sac diameter is 16 to 24 mm and we don't see embryo in that, so we need to review scan after 7 to 10 days. And if we see empty gestation and without fetal pole or cardiac activity within 7 to 13 weeks of this scan, if we rescan this, so we need to again call the patient after 7 to 10 days. And if the discrepancy between the LMP, if with last menstrual occur more than 6 weeks of if we see the gestation sac and LMP happened more than 6 weeks before this visible gestation sac, then we need to recall the patient again. And if the gestation discrepancy of size between gestation sac and the CRL is less than 5 mm, then we need to recall the patient to reassure the things after 7 to 10 days. So another important aspect is to determine the number of fetus, assess the chorionicity and amnionicity. Again, if we find the lambda sign and if intertwined membrane is more than 2 mm, we definitely can say that it is a dichorionic diamniotic pregnancy. And if we find a T sign with intertwined membrane less than 2 mm in the thickness, so we can say it is a monochorionic pregnancy. After it is very difficult sometimes at the second trimester or third trimester to look whether when placenta fuses, whether it was a monochorionic or dichorionic pregnancy. So dating scan is very important in this situation. And again, to predict possibility of twin transfusion in monochorionic pregnancy, if we find some sign of membrane folding and if there is a discrepancy of the bladder size of both the fetus, then we can predict that possibility of the twin transfusion later on. But full-fledged twin transfusion occur only after the 16 to 18 weeks of gestation. But we can have some idea here. And to establish the gestational age accuracy, this is very important thing. What happens with the LMPs? Actually, why discrepancy occur? What happens with this LMP is that the the Naegeli formula takes the regular menstrual cycle of 28 days with when it consider ovulation occur on 14 days of menstruation. But what we see practically that most of the lady cannot recall their LMP properly. And in some studies show that around 50% of the women could not recall their LMP. And those who could recall the reassessment or correction of EDD was considered about in 40% of the cases while they during their dating scan. So it is very important to check the things with the sonography. And another study was conducted in Guna with by Dr. Lalit Sharma sir. They found including 14,700 pregnant lady, they found that approximately 31.8% pregnant women could not recall their EDD, and correction of EDD was considered among 26% of the pregnancy. So it makes very important. It makes important the dating scan. And what should be the method of ultrasound? If patient come before 8 weeks of gestation, always do transvaginal ultrasound. And if she comes after the 8 weeks of gestation, we can try for the trans-abdominal ultrasound if vision is good. And which is the best period for the dating scan? It is always the first trimester anomaly scan, the 11 to 13 weeks and 6 days is considered the best time for dating scan, provided the CRL is taken accurately. Always have patience during taking the CRL. Fetus, what are the criteria? Measuring CRL, fetus should occupy 2/3 of the screen while scanning, and the probe should be parallel in position with the fetus, and maximum length should be considered. It should not moving, and true sagittal section should be taken. It should not show any extension or flexion. We can assure looking a little amount of fluid between chin and the thorax. And if after examination, if CRL EDD taken with ultrasound, discrepancy between the EDD from LMP and CRL, if it occur more than 5 days before 9 weeks of gestation, we need to reassign the EDD. And if discrepancy is more than 7 days between 9 weeks to 13 weeks and 6 days of gestation, then again we need to reassign the EDD. And to estimate the what are the criteria for redating in second trimester scan. If the first trimester scan was not done and LMPs are not, if LMP is unsure, and if it is not corresponding to the composite method where we take BPD, HC, AC, and FL to calculate the average gestational sex, and after and there must be a symmetry that gestational age by BPD, SC, AC, and FL should be corresponding to each other. And if we find that composite methods show difference of more than 7 days between the EDD by LMP and EDD by ultrasound, then consider the ultrasound method before between 14 weeks to 15 weeks and 6 days. And if discrepancy is more than 10 days, then we need to consider after from 16 weeks to 21 weeks and 6 days, then ultrasound method should be considered. And what are the clinical criteria? What are the biometric criteria? How measurement should be done? We need to very sure about the accuracy of measurement in this phase. Cavum septum should be visible, and thalami should be visible at this stage, and it should not have cerebellum in this section, and outer margin of the skull should be considered in the image. And while taking the femur length, we need to take end-to-end endpoint of the diaphysis. We should not we should not include the trochanter or the diaphysis at the, although this doesn't appear at the first trimester scan, the endpoint of the diaphysis should be considered, and the femur proximal to the probe measurement from that should be taken. And while we take the abdominal circumference, the true cross section should be taken, which should include the spine, stomach bubble, and anterior 1/3 should include the mid segment of umbilical vein, and outer circumference of the abdomen should be taken. So these are the criteria. And what are the checkpoints? If mother comes first time directly to us in the second trimester, so check if she is having previous reports, and check in that report if CRL was taken properly. And then we can, if LMPs are not corresponding to the scan, we can take the EDD from CRL at that time. And if patient is directly coming at the second trimester without any previous scan and LMP are also not corresponding, so we need to check the clinical profile of patient. And if she is height, we need to look height, her weight, and check for the transcerebral diameter if it is corresponding the composite method what we have taken. And if things are symmetric, like BPD, HC, AC, and FL are showing the similar, almost corresponding gestational age for that time, so we can consider this scan as we can consider this EDD for further reference. But recall again the patient after 3 to 4 weeks of gestation, and if the growth velocity is corresponding to this only, so we can assign this is first scan as the dating scan. But if these are not corresponding, we need to go through in detail if it is a situation of IUGR or any chromosomal abnormality. If there is possibility of infection, we need to check all these things together. And how should twin be redated? In case of spontaneous conception, CRL of the largest twin should be considered for the dating scan. In case of discrepancy between LMP and the size of the embryo. And what in case of IVF pregnancies, the date of embryo transfer plus age of the embryo at the day of transfer should be added and considered as the LMP for the dating scan. And what should we do if patient directly come to us at the 3rd trimester? So if there is discrepancy between LMP and the fetal size while examination, and this will always going to be a suboptimal study, and we need to document it. And this is not the this is not a assigning scan, but we need to check for the overall environment of fetus, and we need to check this time if what the growth potential baby the conceptus is having. At this time, look at the clinical profile of patient, if she is short stature or not, and look as TCD, cerebral diameter doesn't change much at this time of gestation. So we can consider that thing as a landmark as a gestation is. and we need to check if the distal femoral epiphysis is appear or not. If generally it appears at the 34 weeks of gestation, and if it is visible, then we can assure that the gestation age is at least 34 weeks of time. But sometimes it appear at the 32 weeks of gestation as well. If we see proximal tibial epiphysis or proximal humeral epiphysis at the time of scan, then we can surely say label it as a term gestation. And please document about uncertainty of LMP in this scan. If we are not, if there is a discrepancy at the time of third trimester, and document always about which parameter we have taken as to look for the centile and all things. Like we mostly take head circumference because it doesn't change much. It doesn't affect much if baby is going in FGR stage or not. SC remains almost same, but it is suboptimal study. And what important point to be considered, don't take mean sec diameter as a dating. Mean sec diameter should not be taken for the to assess the estimate gestational age, and decision to change the EDD should be discussed with the patient and should be recorded. And always take proper CRL. Have patient if fetus is moving a lot, recall after second visit, after some time, 20 minutes or 40 minutes, and say patient that you need to void the bladder or take some water, or reassess the patient until embryo is settled, and then take it properly. And 11 to 13 weeks scan should be integral part of every, it should be the integral part wherever we practice. If we generally know what we see, some at some places patients are frequently coming for the first trimester scan, but at the rural or say semi-urban areas, we find that mostly people are not taking it seriously and come at the second or third trimester. If we struggle with such situation, definitely it's the time to go outside and have some campaign, go to talk to the government panels, talk to the college going girls, and the importance of dating scan. We need to spread the health awareness and education program in such areas. Rather we struggle with the screen, ultrasound screen, to check accurately what should be the gestational age. We need to take action according to the circumstance we are practicing there. Generally, in the clinical practice, we don't focus on health education aspect much, but it is a very important aspect to reduce the mortality in overall in this country. And always mention how gestational age was assigned, and elective delivery should not be performed in suboptimal dated pregnancies, and once dating is fixed, do not change at the second and third trimester scan. And other important aspect is to rule out early pregnancy complications. Generally after second and third trimester, we can't it is very difficult to see the surrounding, but in early pregnancy complication, lady may come with the similar complaints like spotting or slight pain in lower abdomen, or all the situation can have similar clinical picture, but only ultrasound can determine what exactly happening inside the womb. If there is a picture of slight peri-gestational hemorrhage, we can carry on this pregnancy with a little treatment and reassurance and the rest. And if in the case of inevitable abortion, where the conceptus is at the endocervical canal, this can only be visible with the first trimester scan, and the situation of complete we can assure only with that. Or the first trimester to assess the environment like adnexa, ovary, masses, or fibroid, the dating scan is very important. Like the small fibroid like this we cannot assess, we can miss more, at the second or third trimester scan. And like any mass are adjacent to the uterus can like 5 or 6 centimeter mass are also we can miss these things after the second or third trimester of gestation. And any adenomyosis like picture which can mimic like a partial mole things, we can easily differentiate during the first trimester scan of the of pregnancy, which is very difficult after the second or third trimester. And first trimester aneuploidy screening, it is very important. Oh, sorry, there's prediction and prevention of FGR and pre. This is very important. Whole concept of Samrakshan campaign is working around this only. And what are the methods we use for screening of preeclampsia and FGR? We take the maternal characteristic as age, height, weight, and ethnicity, and we ask the history of what was the method of conception. If it was a if she was having diabetes or SLE or chronic hypertension, if then we take the ultrasound examination tool as uterine mean value of uterine, mean PI value of uterine artery Doppler, and mean arterial pressure of that patient from both the arms. And Samrakshan is focusing on these criteria. We have the place, because majority of us cannot afford these biochemical parameters at the time, and the detection rate is good if we include these 4 parameters. It's almost 80%. And this situation, if she comes positive, like we cutoff for screening positive is 150. We provide low dose equilibrium 150 milligram bedtime until the 36 weeks of gestation. So this 11 to 13 weeks scan is very important to predict the preeclampsia and FGR situation, which is very prevalent in our country. And for, of course, what we used to see the first trimester anomaly screening. And I'm putting these images that whether patient is coming to you for anomaly scan or not, always check in all the patient these things. These are very essential. If there is equal sign or not, thalami, midbrain, and in the fourth ventricle is visible or not in the true sagittal plane, and knuckle translucency. Always check all this. If the ductus venosus is showing reversal, or it is showing a good waveform, always check for the tricuspid regurgitation, and always do the uterine artery Doppler at first trimester scan. Always check for the sweeping from top to bottom. Check for the third ventricle and this lateral ventricle symmetry, choroid fluxes. Always check developing cerebellum. Check for the maxillary nasal bone and the mandibular gap. And sweeping downwards, symmetry of the lungs, 4-chambered heart, the 3-vessel view. Look for the two-vessel trachea view, and if the possibility of aberrant right subclavian artery. In the cross section, the section of abdomen, look for the integrity of diaphragm, look the stomach bubble and the bladder. We need to check all this thing and try to give this all section in the report, and check if three vessel configuration is there or not, and symmetry of upper limb and lower limb, count the finger in every scan, and the orientation of feet and hands, and to check, always check the skin integrity and the continuity of spine. These all the things at least we need to check in all the cases. And the biochemical screening for the biochemical biochemical marker, first trimester normally can give good detection rate with maternal age, anti, beta HCG and PAPE, and we need to have some idea about the normal value, MOM, normal value of the Indian population. And why I'm saying that, don't blindfoldly rely upon the what interpretation is given there on the lab reporting, because I have seen few reports circulating in different WhatsApp group. One of the case showed that beta HCG was very high and the PAPE was very low, but despite of that, the lab report gave the interpretation of screening negative, and concerned radiologist called them back and showed this discrepancy. Then they changed the report after their concern. So please have some idea, always have some idea what the lab parameter should be for our population. And to assess the risk for the cervical incompetency, it is very important thing to check for the cervical length, because only putting this thing into the report transvaginally, we can save so many birth for complications of the pregnancies later on. Only because at the first trimester scan, given this cervical length in and measured properly in the report, we can save so many pregnancy and stillbirth condition. What are the criteria for the cervical length is it should contain the internal os and external os, and endocervical canal should be visible properly. The anterior and posterior lip of the cervix should look symmetrical and equal, and bladder should always be empty. And if we find a streak of fluid within the endocervical canal, always mention this in the report. And this is how the suture and circulate cervix appear. And this is the Y-shaped funneling, this is U-shaped funneling, and this is the V funneling. Always mention all these things if we find in the report, because after proper treatment, reassurance, and the medication, we can save such pregnancies. And of course, rating scan is important for the interventional decision making, as if we find any increased risk of abnormality through the antenatal screening, the intervention are indicated. The timing of chorionic villi sampling is ideally 10 to 13 weeks, and amniocentesis is 15 to 20 weeks of gestation. If previous child with chromosomal or genetic abnormality or structural birth defect was there, so it indicates for the invasive testing and like that. And to prevent, of course, to prevent preterm birth, postterm birth, and related morbidity, it is very important to have the dating scan. And to make a decision of termination of pregnancy, that we need to exactly know what gestation period is there, because with the gestation age, that method also changes, and after certain period we can't terminate the pregnancy. And to decide on the timing of both medical indication and elective delivery, so confirmation of pregnancy and the accurate dating is must. We can see with this example, the pi value, same pi value of the vessels can give gives different centile value at the different gestation age, and the same value can have the abnormal finding at the different gestation age, like the MCA and CPR are the same value of MCA and CPR PI at the 37 week, 35 weeks and 37 weeks are considered abnormal. So the decision making changes likewise at the for the same value at 37 weeks. We need to follow up the patient weekly according to FGR classification system, and at the 37 weeks and gestation, it recommends immediate delivery, and the same value at 38 weeks of gestation, we can carry this pregnancy up to 40 weeks of gestation. So we exactly need to know what exactly the gestational age is, and this only the dating can only provide the exact gestation period. So I request everyone, if you don't see the patient and frequently at first trimester scan, wherever you are practicing, please have some campaign, go outside, talk to the doctors and talk to the colleges and government person and Anganwadi Asha worker, that spread the awareness and health education about dating scan in your area, because only with that we can save so many pregnancies. This is a very simple step, and we can save we can have a huge difference with that. Thank you so much for your patient listening.
Thank you, Dr. Aganksha, for that presentation. Aganksha has given us a detailed overview on the importance of dating scan. Several aspects has been covered, but as far as Samrakshan is covered, we wanted to highlight the importance of dating scan. We are living in a country where the government has recommended only one scan during the pregnancy. That's a government guideline that has come out so many years ago. And in the 2016 National Family Health Survey says only 60% of our pregnant women has got an access towards ultrasound. The ultrasound uptake in this country is only 60%. So we have everyone who is practicing at different levels of healthcare in India may come across situations where the patient doesn't know the LMP, or maybe patient coming too late to you, and you will be in a very difficult situation to assess the fetal growth, because many times our focus has always been on the structural anomalies or the genetic marker evaluation. But the statistics from Samrakshan tells you that the babies you're going to lose out of congenital anomalies, at least 10 times of babies you're going to lose because of abnormal fetal growth or abnormal fetal-maternal environment. That is why we want to focus on the fetal growth and the fetal-maternal environment. That is why the dating of pregnancy in the early scans are very important. That is why screening for preeclampsia and FGR at 11 to 14 weeks is important. That we want to give a different dimension to our pregnancy scans, to not only limit ourselves into the evaluation of the structural anomalies or the genetic markers alone, but more importantly, any practitioner in India has to pay attention for the screening of preeclampsia and FGR, and also for the dating or the early dating of pregnancy in the early scans, because that is going to be the that is going to be the foundation on which you are going to assess the growth of the fetus at a later stage, and the Doppler parameters, which will give you reasonable good understanding about fetal growth. It's not just the biometry alone. It's the Dopplers are essential part of growth scan. So a growth scan is not just biometry alone. Doppler scans, percentiles are very important. But if you don't have a proper early dating scan, and if you're going only by the LMP which the patient has given, you may be very wrong in the estimation of the Doppler percentiles, and thereby giving rise to preterm, helping the giving wrong assumptions, wrong interpretations to the obstetricians, and maybe you will be delivering preterm births more. So these are the implications of the importance of early dating scan and the impact on the perinatal statistics. That's a paper that was published by Dr. Lalit Sharma here from his 10-year study from Guna on 14,700 pregnancy. That is published in our IJRI, Indian Journal of Radiology Imaging, in the 2020 March or April edition. You can refer that. That's a very, very interesting study that since Dr. Lalit Sharma is also here, I was also a part of that study, myself and Praveen. And we just wanted to highlight the importance of that study. The context was high perinatal mortality in India may be caused by inaccurate dating of pregnancy, resulting from suboptimal uptake of antenatal care and ultrasound services during pregnancy. And the aim was to determine the discrepancy in the last menstrual period, assigned expected date of delivery, and ultrasound assigned expected date of delivery in pregnant women in a rural district of central India. And the results, the program screened 14,701 pregnant women, of which 4,683 or 31.86% could not recall LMP. EDD assigned by LMP and ultrasound matched in 7,035 of the remaining 10,000 pregnant women, but EDD was overestimated by LMP for 26%. So these fetuses were at risk of being misclassified as term fetus. And in 2018, the project, so once this early dating scan has been integrated into their practice, there was a significant change, and also the preeclampsia and Fgr screening in their practice after the Indore CME on Samrekshan. They changed their protocols, and then the maternal deaths were less, were almost nil, and the infant mortality and the perinatal deaths also significantly reduced. We can hear from Dr. Lalit Sharma on this particular study. Dr. Lalit sir, would you like to contribute a few? I almost mentioned about that study. Before we going into the discussion session, which will be taken by Dr. Anjali and Lalit Sharma sir, I just want to hear from the researcher from Guna, who is a social radiologist from Guna, who is a very essential part of our Samrekshan project. We have got certain models to showcase on Samrekshan. And Dr. Lalit Sharma's Guna model, the IRIA Samrekshan, the Barossa model that he has already taken along with the district administration and is doing extremely well. It's a role model that the country has to look into. Lalit sir.
Thank you very much, Dr. Rijo, for kind words. Actually, it is really a social work. I attended the cusp at Madras of Dr. Suresh conference in 2004, and I purchased a book of Donald, and there I saw a chapter in that book which highlighted the importance of dating. And then I started working on that, and I saw in my central part of the India, most of the pregnant mothers, they don't know the LMP. So I started documenting the everything and then assigning the EDD. That is the essence of that study, and I started that since 2004, but documented from the when I became a president of Rotary Club of Guna as a Rotary MCH product. 2011, 14th of November, then I included all the Anganwadi of Guna, started from one Anganwadi center, and today I am working on 168 Anganwadi. And even today you have highlighted all the up to 2020, but today even in Samrakshan and all my work, even the 33% of total population is not according to the LMP dates. And one important I want to highlight at this moment, our Central Indian women, whether of any caste, they say when we ask the LMP, they say the last date, because they think they cannot worship the god, okay, when they are menstruating, and that day may differ from 3 to 7 or to sometimes 10 days. The bleeding continues and they cannot worship their god. So, it is a huge difference. You can when we evaluate the FGR and decide the timing of delivery, it becomes very important. And I have seen many cases, if you do not correctly define the EDD and the LMP gestational age, many of the children were dying. And thanks to you, Dr. Rijo, because I was working on the gestational age defining EDD, and that was one of the cause of the low birth weight, post maturity, preeclampsia, which was the cause of this preterm birth and post dated birth. But I was not thinking about the Doppler. After the, because I was wondering why I am not able to reduce the stillbirth. The stillbirth were occurring, and thank to you for introducing submersion from the day 1, hearing you on the 1st of the September. I included Doppler in my studies, and there is a tremendous change. There is tremendous change. Thank you very much for this. So I want to emphasize, please document the EDD and ask, because our most of the ANM and Anganwadi workers, they are not doing the correct dating, and dating is done by the in the MCP card by the ANM, not by the qualified doctor, or nor even our radiologists, they are not writing the method of assigning the EDD. They simply, and I have seen many reports from the Delhi, Madras, Metros, all Bombay, from big institute, they are simply writing the gestational age plus minus 1 week or 2 days, but they are not assigning it. We have to assign the EDD and then follow. So, this is very important aspect I want to highlight. No one is assigning. They write gestational age by EDD like this, gestational age by ultrasound plus minus 1 or 2 week. It does not make any difference. No
Yes.
sense at all. So
that's a very important point Lalit sir has highlighted. Many of us have the habit, even in the metros, that's what he said, it reports from many parts of our country, even from metros, people keep on giving the dates. Expected date of delivery, that once assigned in your early dating scan, you are not supposed to change it after that. So every scan you don't have to give EDDs, and every day, every scans you do. That is a wrong tendency. That's a wrong way of approaching this. So if the obstetricians are not comfortable with that, you have to tell them, you have to inform them that is EDD assigned in the early scan, that is to be followed. But can we rely entirely on the LMP given by the patient? No. In India, at least no. Western countries, it may be, to a certain extent, it may be right. But India, we have got problems. Even the
no, even in Western, their literature says the 40% doesn't know.
Wrong, yeah. Yes. So it is basically because of the irregular cycles or whatever reasons are there. But then it is essential for us to assign the EDD in the early dating scan and not to change them in the subsequent scans. That's an important teaching point that especially as far as subrection is concerned, as far as the practice is concerned in India, when we are going in a direction where we are giving more emphasis to fetal growth and fetal-maternal environment, apart from our emphasis already that is given for fetal structural evaluation and genetic marker, chromosomal marker evaluation. So we are again emphasizing that point in subrection, that our pregnancy scans are not just structural anomalies, structural evaluation of the fetus. We have to emphasize on the fetal growth evaluation, any abnormality in fetal growth, and also on the fetal-maternal environment, because preterm babies or prematurity and complications, and also related intrapartum complications are the major contributors to perinatal deaths. It's not congenital anomalies. It is 6 times more than the congenital anomalies. So it is high time for any practitioner in India to pay attention to fetal growth and fetal maternal environment. And one of the important points that we want to make here is to assign the EDD in the early dating scan, and also to integrate the preeclampsia and FGR screening in your 11 to 14 week scan. So let us move on to a discussion that will be led by Dr. Anjali Gupta and Dr. Lalit Sharma sir. And I have to introduce another Samrakshan leader of the last 3 years who made phenomenal progress and who did phenomenal work for Samrakshan. And she's from Agra. She's Dr. Anjali Gupta. She's from Agra, and she's a very good teacher, and she has been providing help for not only for the radiologists, reaching out to the obstetricians, to the neonatologists, interacting with them, making them aware about the Samrakshan protocols, importance of Dopplers, and for better perinatal outcomes. She has contributed immensely, along with Dr. Akansha and Dr. Lalit, all in different parts of India. Madhya Pradesh and Uttar Pradesh were two states where I passionately wanted to take some direction forward, because if we can make a difference in these two states, at least 4 or 5 states in the northern part of our country, Rajasthan, Uttar Pradesh, Madhya Pradesh, Bihar, and Odisha and Chhattisgarh. These 5 places contribute to 55% of perinatal deaths in India. So we need to find out leaders, Samrakshan leaders from different parts of these states, and it is them who have to perform, then who have to do the work there and spread the awareness, put these things into practice, interact with obstetricians and neonatologists there, and make a difference to the perinatal and maternal statistics there. So I'm not taking more time. Let us move on to the next part of our academic session. That will be a discussion on the importance of dating, that on different case-based scenarios will be shown by Dr. Anjali and Dr. Lalit in this discussion. Over to you, Dr. Anjali.
For her introduction, at the outset, I would like to thank Dr. Rijo and Team Kerala, and would like to welcome our chief guests in the process. Is my screen not visible?
Yes.
So after a very beautiful presentation by Dr. Akansha, in which she has so elaborately enumerated all the tenets of a essential dating scan, I will show a few examples which will highlight whatever she's said, and will tell us the important practical applications of whatever she has taught us. Dating is an integral part of any obstetric workup. Why? Because essentially we are interested in knowing whether our particular fetus is growing well or not. So what is growth? Growth is not growth. A growth scan is not a single scan. It is always a sequence of events that will have, which should be in the optimum time frame and in the optimum growth trajectory. So how do we know whether our particular fetus is growing well? We have to have a reference point from which we know whether the interval growth of the fetus is proper. So how do we establish that reference point? A dating scan is, and which will establish that particular reference point from which we can know it is falling from the growth. We have to have that reference point. So that is what a dating scan is. So, so this was a practice bulletin which came out in 2018. It has been very well elaborated.
Anjali, it seems there is a connectivity issue. Can you switch off your video, and then the audio will be better?
Okay, sir. How do I do that?
Yes. It's okay now.
Let's start video, that you press on that.
Yeah.
Okay.
Better now?
Yeah, better.
So, if we come to this particular chart, I recommend all of us as a good practice point. We should get this printed and put it up on a green boards in front of our machines, so that every time we don't have to really remember what to do. Once we see that the CRL is discrepant, then what the gestational age should be according to her LNP. So this is this was brought about by the AIUM practice bulletin, and this has been very well told by Dr. Akanksha, and this gives us what is the discrepancy period in which if suppose the gestational age by our examination of CRL comes out to be more than 5 days than what is projected by the LMP which the patient is telling, then we have to go ahead and re-establish the or reassign the EDT to the particular patient and redate the pregnancy. If it is less than that particular period, then we don't have to go ahead and redate the pregnancy. So I recommend that all of us get this chart printed and put up in our OPDs in front of our machines for an easy day-to-day practice. So coming to the first case, suppose this first case, this is a lady who told us that her LMP was 1st of January 2022, and our machine tells us that EDD by LMP would be 7th October 2022. Now, when we did the ultrasound, her CRL was 6 weeks 6 days, as against 7 weeks 5 days, which should have been the case if her LMP was correct or she had conceived according to the LMP or the Naegele's rule. So, what do we see here? That the discrepancy between the two figures, that is the gestational the gestational age that should have been there by LMP and by our measurement is 6 days. So, do we have to redate this pregnancy? The EDD by LMP is coming out to be 7th October, but by USG 13th October. What do we assign her? She has come to us for a dating scan the first trimester. What should we tell her? So, should we redate this pregnancy or not? So if we go back to our chart here, we very well can say that she falls in this range, that is 8 weeks 6 less than 8 weeks 6 days range, and if the discrepancy is more than 5 days, we have to redate this pregnancy. So yes, we have to redate this pregnancy, and we have to give that in writing in our impression also. In what our impression is that the EDD has been reassigned to 13th October 2022, and this is the particular EDD which we have to look when she comes for us in her next scan, so that while we enter it in our machine, we have to enter not the LMP of the patient but the projected EDD of the patient. That way, the machine will tell us that what is the correct gestational age which the fetus actually has, that how old the fetus is, and then we assess her growth according to biometry and judge whether the fetus is growing correctly or not. So if we come to our second case, here again this lady has an LMP of 15th January 2022, and the EDD by this LMP which is projected by the machine is 21st October 2022, and she is now 12 weeks 5 days of age. Now again we do her CRL. Again the CRL comes out to be 12 weeks 0 days. Again 5 days discrepancy. So do we redate this patient or not? The machine tells us that the EDD by USG is 26/10/2022. So do we write this in our report, this EDD in our report, or do we not write it? Alex, that is going to tell us.
Yes.
So, sir, in the 12-weeker, do we redate this pregnancy? So, if we come to again to that particular table, which tells us that yes, this is a 12-weeker. So, this falls in this particular group, and the discrepancy is only 5 days. So, we have to redate when the discrepancy will be more than 7 days. Here, we don't have to redate this pregnancy because the discrepancy is only 5 days and not 7 days. So the answer will be no, we don't have to report this pregnancy. In our report, we have to write the patient LMP is 15th January. The EDD still remains 21st October 2022, and our gestational age as of now is 12 weeks 0 days. We don't have to redate this pregnancy at all. So, for all practical purposes, the patient, if she's coming to us in nuchal translucency NT-NB scan, Then 5 to 7, if the variability is more than 7 days, then we have to reassign the EDD. But if it is less than 1 week in the NT&B scan, not less than 9 weeks, but more than 9 weeks, 6-day scan, then we have to not reassign the LMP. But if the discrepancy is more than 1 week, we do have to reassign the LMP. Now, next common time when the patient comes to us for her dating is the for her scan is the second trimester or the level 2 or the TIFA scan. So this is another case which will tell us what we have to do. So suppose her LMP is 22nd January 2022 and now her EDT by LMP was 28th October and the gestational age is 19 weeks 6 days as of now. So okay, so we expect that our ultrasound will show 19 weeks 6 days, but our composite gestational age at 19 weeks according to BPD, HC, AC and FL comes out to be 18 weeks 1 days. So that is the discrepancy is of 12 days. So what do we do now? The EDD comes out to be 19/11/2022. So do we write 19/11/2022 in our, on our report, or we stick by the EDT, the LMP? Again, if we go to that particular table, the table tells us that our fetus falls in this category, that is 16 weeks to 21/6, because it is 19 weeks 6 days. And we, according to the composite EDD, if there is a discrepancy of more than 10 days, we have to go ahead and redate this pregnancy. So do we redate it straight away? So
Yes.
actually, yeah, we have to redate it. But again, broadly speaking, if the patient comes to us in a TIFA scan, then we have, if the discrepancy is less than 10 days in a TIFA scan, we don't have to reassign the LMP date. And if it is more than 10 days, we have to think of redating the pregnancy, provided we have a previous scan which tells us that the dates were accordingly. I'll come to that in a bit from now. Now, again, same case. This was our case 3. The lady had 18 week 1 day of gestation and we redated her. But this is another case. Look here. If we see in this case 4, she again has the composite age of 18 weeks 1 day. But there is a different story which the biometric tells us. In the case 3rd, everything was falling behind, even the BPD, the HC, the AC, the FL, everything was falling behind her gestational age of 19 weeks 6 days. And so we redated this pregnancy. But what about this case? Here, 2 parameters, that is the head parameters, were quite corresponding to her gestational age by LMP. And the AC and FL were the parameters which lagged behind. So what does this case tell us? What do we redate both of them in the similar manner? No, but these parameters tell us a different story. They tell us, no, there is something wrong happening with that baby, and maybe this is the case which we have to consider before redating. Maybe this is a big baby, this is a normal sized baby with an abnormal growth. So this is what we don't have to blindly look at the average gestational age projected by our machines, but also apply our head into the biometry. That is, while scanning only BPD was 19 weeks, now AC is 14 weeks, there is something wrong happening with my baby. I have to be alerted. So again, if we elaborate on this case, this was the same lady, this was another lady with the same problem. That is, the LMP was 22nd January 2022. Her EDD was 28th October, which was projected by her LMP. Gestational age 19 weeks 6 days, same gestational age composite by biometry, and the discrepancy of 12 days. Do I redate her actually? So how do we go about it? We see whether there was any early dating scan available. Unfortunately, she came to me at 19 weeks, and this was her first scan which was happening. That is a usual case in North India, at least. Ladies don't turn up for the first trimester scan. So no, I don't have another scan available. Average gestational age or multiple parameters, are they similar? In this particular case, they are not similar. If AC is small and BPD and HC are in acceptable range, as is our case, then we have to consider possibility of very early FGR. Maybe growth restriction because of placental insufficiency, or some infection, or some chromosomal abnormality, or even skeletal abnormality. So we have to keep this in mind and not hurry in redating the scan, not hurry in redating this pregnancy, but hold our horses, call her again after 3 weeks, which is a optimum time in which her interval growth or growth velocity can be estimated. We call her again after 3 weeks, and if the growth is in the same trajectory, then we redate her pregnancy. Otherwise, we label it as a sort of some growth restriction, which is requiring, because it is an early growth restriction, it will require an infectious screen, a further screen for any anomalies, and even a basic Doppler. So this is our case 4. In this particular case, do we redate her pregnancy? In this particular case, when the parameters are not corresponding to each other and the AC shows significant lag, then we don't redate her pregnancy. We call her again after 3 weeks. Now, this is the usual case. They don't come as I'm sorry. They don't come to us at 22 weeks even. They come after that for the TIFA scan. And in such scenario, the difference becomes not 10 days, but 14 days. So if she comes to us between 22 to 27 weeks, then again, we have to go to our, to see whether the discrepancy which is projected by the LMP and that which are biometry, if it is more than 14 days, then we have to think about whether we have to redate it or not, on based on the condition that yes, her parameters are corresponding to each other. All the parameters are within the normal. Here is another case in which this particular patient has an LMP of 1st December 2021. Her ETT by LMP was 8th September 2022, according to the LMP, and the gestational age is 25 weeks. So, and the gestational age by my biometry was 22 weeks 4 days, showing in 18 days of difference. So ETT by USG on my machine was 26th of September, 8 to 26, that is 18 days of difference. So again, do I redate this pregnancy or not? So what should I do? I should always look at her previous report, and she had a first trimester USG in which already the ETT by USG was 24th September 2021, because that is, she had already been redated before. So what I find is that my growth was corresponding. So should I redate it or not?
Yes, we need to go according first trimester.
First trimester. Only by first trimester.
Only by first trimester scan. Our table tells us that we have to redate it if the discrepancy in this time frame is more than 14 days. It tells it, but however, with our algorithm, if there is an early dating scan available, in our case, yes, we have an early scan which is available and it has already been redated, then use the first trimester EDD only for interval growth. So in my machine, I don't have to put in LMP of this 1st December 2021, but there is an option in my machine in which I am putting LMP that what was the projected EDD in the first scan. There I have to put in 24th September 2021, and then the GA by the first USG would be somewhere around 22 weeks and 6 days according to what her EDD by USG is. So in this particular case, I will never redate the pregnancy because she already has the first scan in which the redating has already been occurred and the growth is optimum according to that. So and what do we do beyond 26 weeks? It is preferably avoided because there is a lot of discrepancy between the various parameters, the biometric parameters, and usually if the patients are presenting late and they don't have previous scan, it is always better to first establish what the parameters say and then call her again after 3 weeks to assess whether the growth velocities are they're normal or not. And again, as Kanksha told and Sir also told, that after fixing the gestational age once in her scan, you do not have to change dates in subsequent scan. Your subsequent scan should never have the EDD by USG in your report. Never do that. And even if the gynec asks, you have just to tell her one line that her EDD remains as was projected in the first scan. don't use machine generated data blindly. There are two examples which I have given which prove that. One, when she already had a dating scan done, and second, when the parameters, the average gestational age was 18 week one day in both pregnancies, but once one pregnancy we redated and the other we considered to be having no FGR. So we have to learn to test this in our calculate this in our minds as we do our biometry. See, these are discrepant biometric parameters. We have to consider this to be FGR or some form of growth restriction due to infections or chromosomal anomalies rather than a simple redating mistaken dates or delayed irregular periods or something like that. Then there is one 8% rule. I have not practiced this in my of the radiology by this rule that if you see what the difference between the station that is conducted by the LMP and by your scan is if the distance is more than 8%, then you have to read it. But you have to have this software inculcated in your machine. Then only it becomes easy. Otherwise, this is very cumbersome. So personally speaking, this works for many people, but for me, I use the AIUM chart. I have stuck that in front of my machine and there are few frequently asked questions. Um, can getting be done by means of diameter if I don't see an embryo?
No.
No, we don't.
No. No.
So by all particular by consensus and by that paper which I showed of AIUM, they say that you have to when you see a visible embryo and with a visible heartbeat. Unless you see visible
Anjali, your voice is again.
is it okay now?
Yes, yes.
So you have to redate this pregnancy only if you see a visible embryo and a visible heartbeat.
Yes.
Again, what is the best gestational age for redating? Is it 6 weeks? Is it 9 weeks? Or is it 12 weeks? Suppose the patient came to me at 6 weeks and I find, and then again at 12 weeks or at 11 weeks and I find that the growth is suboptimum. So which one will I opt for redating, Akanksha?
11 to 13 weeks scan should be considered because 6 weeks or 7 weeks embryo is sometimes most of the time it is flexed, and when it the one and this is the period of exponential growth, and afterwards this 1 difference also translates into the long difference in first trimester 11 to 13 weeks and later on second trimester. So if we see the CRL with cardiac activity, always mention it in the report that reassessment of the gestation age should be done at the first trimester anomaly scan. So if there is discrepancy in both 6 or 7 week scan and properly taken CRL of second trimester scan, then first trimester scan, then 11 to 13 weeks and 6 days of CRL should be considered for the reassigning the dating.
Correct. So basically, if you look at the embryology, there is unfolding of the embryo which happens at 9 to 10 weeks. So after that, only the proper the CRL will correspond to proper gestation. So before that, you might be measuring a curved embryo. So if you have two first trimester scans, then the 11 week or the more than 9 weeker scan would be a better scan for exact dating.
Yes.
So once an EDD has been established either by LMP or by CRL, can it be changed in subsequent scans? I see reports in which she has different EDD in different scans. Even I was doing that before Samrakshan happened to me. Even I was doing the same thing in my every scan, the first scan, second scan, third scan, fourth scan. Every scan had a different EDD. So, so once EDD has been established, should it be changed? Can it be changed in subsequent scans?
No.
No, it should not be changed, because sometimes it is the indication, if it is growth is falling, it is indication of some alarming sign, either infection or uteroplacental insufficiency is happening, or some aneuploidy. We can miss if we redate the things, and we can land upon some complication during delivery, because we don't know exactly what the gestation period is that time of the pregnancy.
So, if at all any EDD has to come in your subsequent report after the first report, it has to be EDD either by LMP or EDD either by first USG. That should be documentation in your subsequent report.
Yes.
This is the EDD by her first and then first USG, or this is the EDD by LMP, which was corresponding in her first USG. So you have to make a note never to repeat EDD by what your machine says if she has had a dating scan before. Suppose the EDD has been reassigned in the first trimester scan. How do I proceed? What should I enter in the patient characteristics on my machine?
Put the EDD. Put the EDD.
So every machine has 2-3 options in the scan. Either the exact gestational age you can put, or the LMP, or the EDD, or corrected EDD. There is an option on the machines. Once you enter the basic patient's parameters, that this is her name, this is her age, this is her reference, referring doctor, you can also enter her LMP. That is how you get to know what her exact gestational age is. So suppose it has been redated in her previous scans, then you have to enter the corrected EDD on your machine, so that it will tell you exact gestational age, which is the expected gestational age if the fetus has a good growth trajectory. And then you see what your biometry tells, and then you decide whether this is a growth restricted fetus or not. So that is the importance of putting the correct thing in your basic patient parameters on the machine, because then it makes your life very easy. Now see, I see a growth lag of, then you can call it a growth lag. You don't call it a discrepancy, then you call it a growth lag of 7 days or 8 days or whatever. So that is the importance, that in your machine you have to always enter the corrected EDD. And how do we do that? You have to make it always a point to look at her previous report. She has come to you for an anomaly scan. You don't straight away start the anomaly scan before having a peep into her first trimester NTNB scan, or maybe the dating scan. Once you have done that, then only you proceed with the PIFA. Otherwise, your job will be only half done. So this is a good practice point, that you always in the subsequent second trimester, third trimester scan, you always have to look at her previous reports. You have to make this a habit in all your obstetric scans, that always ask for the previous reports. It is very easy. You just have to ask your staff to send all the file, all the papers of the patient when she enters your chamber. Otherwise, you don't scan the baby if the patient doesn't have the file. You don't scan the lady, ask her to wait until she brings the file from her doctor's OPD. Usually they keep the file at the doctor's OPD and can then come to you for an ultrasound.
Mostly happens, or at the home.
Happens. So you have to make it a point that you scan the lady only if she has her previous report, and you make it a point of looking at the previous reports before starting the scan. It will take 30 seconds, or you can train your staff to give, as the lady is being shifted and given position by the staff, you can in the meanwhile just look at her previous reports. So that is a good practice points. That these are simple practice points which will make your which will impart accuracy to your reporting. So this is what I have to. This is my bit for today, and over to Dr. Rijo, sir.
Thank you, Dr. Anjali. I think this is a very good discussion on the importance of dating scan. Various practical scenarios were discussed by Anjali, Agancha, and Lilith sir. And as part of the Samrakshan project, we just want to highlight this point again and again, because there are lots and lots of wrong practices happening in various parts of our country, and giving ADD several times in all this thing, and no early dating scans are not being taken properly. Early dating scans are not being asked because there are awareness is very less in some cases, and then there are lots and lots of issues. But you, as a leader in healthcare, a leader in the pregnancy and child care, you can educate the patients as well as the referral doctors, the obstetricians, and ask them that these scans are important for reasons, especially when we look at from the point of fetal growth and the fetal maternal environment, not only just structural anomaly evaluation. So the importance of this session is, I just want to highlight it again and again: accurate dating of pregnancy and systematic follow, integrating the radiology and imaging parameters of biometry and Dopplers, and adequate obstetric care for appropriate risk-based management of pregnant women in India can significantly improve the perinatal statistics in India. This is a very, very important, because 60% of mothers do not know their LMP, or even if they tell you an LMP, the expected date of delivery can be wrong, either an underestimation or an overestimation. So dating scans are very important, and once assigned, and you have to take it properly too, and once assigned, do not change the date, follow that date, because fetal growth assessment based on the percentiles of biometry, the Doppler percentiles, everything is more important, because unless you don't have a proper dating scan, if you're going by the dates given by the patient, your percentile calculations, either of the biometry or of the Dopplers, can give you wrong assessments, and you may be advising your doctor, your obstetrician, to deliver the baby early or too late. And these can cause premature babies, or this can cause stillbirths, or this can cause a lot of perinatal morbidity
complications.
Morbidity too. So this is the why we want to highlight to every practitioner of Samrakshan all over India, especially those who are in the, because you are the people who are going to, you know this, you are the people who are going to educate the patient, you are the people who are going to educate your obstetricians about the importance of a dating scan, and various practical scenarios has been described here by Anjali. When the patient comes to you without knowing, without a previous scan, what are the difficulties that you are likely to face, and when they come directly for a second trimester scan, what do we have to do? And all these scenarios will be definitely, all of you are going to face them in your practice. You must have already faced it, but you might not have paid enough attention. You might have given enough attention to all these things. But for the sake of our babies, for the sake of our mothers in India, if we truly want to reduce the perinatal mortality, if we truly want to reduce the maternal mortality in India, these are the simple measures that all of us can take. So please do pay more attention to all these things. Daily dating scans, take them up properly as advised and shown to you by Agansha, and various clinical scenarios on the importance of dating scan has already been discussed